Bismillah ar-Rahman ar-Rahim. In this lecture, we discuss one of the respiratory tract disease in children, what's acute stridor in children. Our learning objective of this lecture, a clinical evaluation of a child with acute stridor, detection of life-threatening cause of acute stridor, emergency treatment of acute stridor in children, family counseling regarding home care, medications, and danger clinical features. So we start with a case history scenario. A 2-year-old child who has developed noisy breathing on inspiration, marked retraction of the chest wall, flaring of nasolabial, and barking cough. He had mild upper respiratory tract infection for 2 days for this attack. What is the most likely diagnosis? By looking to this case scenario, we look to the age of the baby, it's around 2 years. He had noisy breathing, there are sound on his breath, mainly on inspiration, and there are signs of retraction. The elevation is dyspneic, retraction of the chest wall. We have flaring of nasal, and there are characteristic barking cough. And this could be happening with some disease in the respiratory system. The condition is preceded by 2 days history of flu-like illness, so there is not an acute severe condition. There are no high-grade fever and no mention that the patient is toxic. So in this case, what could be the likely diagnosis regarding a case of acute stridor? There are no evidence of foreign body, and the patient is not toxic, and he is previously well. There are no mention have some problem. So the most likely diagnosis, laryngotracheobronchitis, or commonly known as a croup. What's the common noisy breathing this patient developed? What could be? This is stridor. So the noisy breathing associated with barking cough is stridor. How can we define stridor? Stridor is a harsh, high-pitched respiratory sound, usually inspiratory, but may be biphasic, inspiratory and expiratory. So stridor above the glottis level or vocal cord is mainly inspiratory. At the vocal cord it's biphasic, and at the lower than the vocal cord could be expiratory. What are the main causes of acute stridor in children? First and the most common is laryngotracheobronchitis, or commonly known as a croup. Second, acute epiglottitis or supraglottitis. Laryngeal foreign body as food such as nuts, popcorn. Bacterial tracheitis, and diphtheria or diphtheritic croup. So this is the main cause of acute stridor. We will discuss later on each one separately and how can we differentiate between each of the following causes. How can you classify stridor according to the clinical severity? So babies come with stridor or or child come with stridor, you had grading regarding severity. We have grade 1. There are exertional stridor. Stridor only appear on or during exercise or crying. The baby, if you have not do any exertion, there are no stridor. Grade 2 stridor at rest. Stridor at rest and become worse with crying. The baby gets stridor at rest, but it becomes more severe when he's crying or make exercise. Grade 3 stridor with retraction. There are stridor at rest with suprasternal and supraclavicular retraction. So the baby has distress, respiratory distress with stridor. And lastly, grade 4 stridor. Stridor with cyanosis, stridor with retraction, cyanosis, and disturbed level of consciousness. The baby may be agitated, lethargic due to severe hypoxia. So this is the main grade of clinical grading of stridor. What are the causative agents that causing croup or laryngotracheal bronchitis? As we mentioned, most of the respiratory problems in children, they are viral problems. So the main cause is parainfluenza virus type 1, 2, and 3 is the predominant cause of croup in 75% of cases. Other causes, influenza A and B virus, adenovirus, respiratory syncytial virus, and sometimes measles. Mycoplasma pneumoniae are a bacteria can cause croups. Only bacterial causing croup is mycoplasma. Epidemiology. Most patients with croup, they are between 3 months up to 5 years, with a peak in the second year of life. So the age of problem ranges from 3 months to 5 years. Higher incidence in male and during winter. So it's more common in male and winter time. So it's seasonal disease. What are the main clinical features? How the patient come to us? Firstly, there are signs of upper respiratory tract infection with some combination of rhinorrhea, pharyngitis, mild cough, and low-grade fever 1 to 3 days preceded the problem. So in most of cases of respiratory tract infection, there are preceding history of prodromal symptom of cough and rhinorrhea. The child then developed the characteristic barking cough, hoarseness of voice, and inspiratory stridor. Symptoms are worsened at night. Patients have more severe at night and decreasing over several days and usually resolve completely within a week. So the symptom is gradually increasing, then later on decreasing. Agitation and crying greatly aggravate the symptoms and signs. So it's proper to keep the child quiet, not make him in exertion or not make him crying, to not make his more distress. How can we diagnose croup? In most of respiratory problems, the diagnosis is clinical diagnosis. So, history of flu-like illness, followed by barking cough, hoarseness of voice, low-grade fever, preceding prodromal phase, and characteristic stridor. Those more suggestive of croup. We may do radiography of the neck, may show the typical subglottic narrowing, or what's called stable sign on a posterior anterior view. We rarely do this X-ray for the diagnosis because most of cases we can't diagnose. And this picture shows subglottal stenosis by radiographic feature what's called stable sign. How can you manage this patient? Treatment of croup. The mainstay of treatment and airway management. Most of children can be managed safely at home. We can ask the family to give some antibiotics, some analgesic. We keep the baby quiet. We can give him even oral dexamethasone syrup for laryngeal oedema to improve his condition and follow up the patient. And most of the patient is mild problem. Treatment in the hospital for patient with respiratory distress, severe stridor, we can use of cool mist by tent or face mask to moisten the airway secretion. So we can use oxygen or humidified oxygen as we mentioned previously. Second, you can use nebulized epinephrine. And this will decrease in the laryngeal mucosal edema. The indication for the administration of the nebulized epinephrine include moderate to severe stridor at rest, patient that need for intubation, respiratory distress and hypoxia, when stridor does not respond to cold mist. So in this condition, we can do nebulized epinephrine. Patient may safely discharge home after 2 to 3 hours period of observation, provided they have. So, what are the indications for discharge? Patient. The baby have no stridor at rest, normal air entry, normal level of consciousness. Other part of treatment, corticosteroid. Corticosteroid decrease the edema in the laryngeal mucosa through their anti-inflammatory actions. IM dexamethasone, oral dexamethasone, and nebulized budesonide have equivalent clinical effects. So we can use steroid locally, systemic, IM or inhaled steroid on systemic, all can affected. We can give him 0.6 mg per kg of dexamethasone effective in patient with croup. Antibiotic is not indicated in croup because it's a viral infection, so there are no rule for antibiotics. Helium, oxygen, or what's called Helox. It's a mixture of helium and oxygen in 70 to 30%, have similar clinical improvement as racemic or nebulized epinephrine. Sometimes can be used if available helium or oxygen. Whose patient need hospitalization? So what are the indications of hospitalization? Baby with progressive stridor or child with progressive stridor, severe stridor at rest, when there are respiratory distress, hypoxia, cyanosis, when there are depressed mental state, patient is agitated, lethargy, or disturbed conscious level. So we finished the group or laryngotracheal bronchitis. Now we'll discuss another cause of acute stridor. There are history scenarios. A 6-year-old boy presented to the emergency department with a 6-hour history of fever and respiratory difficulty. On examination of patient is looked toxic, temperature of 30 degrees centigrade, tachycardia and tachypnea, withdrawing. His distress increasing with crying. So, by looking to this case and compare with the previous one, the child is older, 6 years old. He had rapid onset within 6 hours and he had high-grade fever, 40 degrees centigrade. He looked toxic and severe respiratory distress. And the stridor is not much present in this case. So what's the most likely diagnosis? This is not a case. So the most likely diagnosis is what's called acute epiglottitis or supraglottitis. It's a severe medico-surgical emergencies. So, epiglottitis, as we say, it's a severe problem and it's usually sudden onset. It's caused by Haemophilus influenzae type B. Most often occur between the age of 2 to 7 years. It's an acute fulminant course of high fever, sore throat, dyspnea, and rapid progressive respiratory obstruction. And within a matter of hours, the patient appeared toxic, swallowing difficulties, so he got drooling due to swallowing difficulty, he got dysphagia, and breathing is labored, so it's difficult in this breathing. Drooling is usually present and the neck is hyperextended in an attempt to maintain the airway. A special position, the child may assume the tripod position. He's sitting upright and leaning forward with a chin up and the mouth open while bracing on the arms. So this position to open his airway properly. So the patient is toxic, high-grade fever, drooling. He has severe respiratory distress and cyanosis and within a matter of hours. A brief period of air hunger with restlessness may be followed by a rapid increased cyanosis and coma. Stridor is a late finding, not like a croups. And if not you deal probably with this patient, he may die from this severe hypoxia. How can you confirm the diagnosis? So, for history, the diagnosis of epiglottitis mainly is a clinical diagnosis. We suspect the patients from clinical feature, toxic, drooling, and high fever. The diagnosis is confirmed by direct visualization of the large, cherry-red, swollen epiglottis by laryngoscope. This procedure should be performed in an operating room or intensive care unit with a complement surgeon and anesthesiologist prepared to place an nasotracheal tube or to perform a tracheostomy, because procedure may cause complete respiratory obstruction. So, if you find a patient with suspected epiglottitis, please don't touch his throat. Don't examine him by a tongue depressor. You may precipitate sudden death by complete obstruction. If you suspect patient with acute epiglottitis, the immediate action to transfer him to the theater room with the presence of the surgeon, anesthetic, and to try to intubate him. So the intubation is mandatory. We can do blood culture and culture from epiglottis. When you try under general anesthesia, you can take swab for culture and sensitivity. So clinical diagnosis plus direct inspection of epiglottis plus blood culture. There are lateral X-ray of the upper airway may show what's called thumb sign. And you take a radiography of the neck. So this is a thumb sign, swollen large epiglottis. This table shows the difference between epiglottitis and croup. When take some parameters, the voice is hoarse in croup, it's muffled in epiglottitis. Stridor is loud in croup, it's quiet in epiglottitis. Dysphagia not present in croup, but it's present in epiglottitis. Drooling, no in croup, yes in epiglottitis. Sitting up position not present in croup and it's present in epiglottitis. Barking cough characteristic for croup is absent in epiglottitis. Toxicity not in patient croup, it's present in patient epiglottitis. And fever, it's low grade in croup and high grade in epiglottitis. So other than this differentiation, baby with epiglottitis usually have sudden onset. He is bacterial infection and croup is viral infection. Also the age of attacks, usually it's younger in croup rather than older in epiglottitis. Treatment of epiglottitis. Epiglottitis is a medical emergency. An artificial airway by nasogastric, nasotracheal intubation or by tracheostomy to all patients regardless the severity of the respiratory distress. So mandatory, all patients need to be intubated, usually for 2 to 3 days, and should be done in the operating room or intensive care unit. After insertion of an artificial airway, the patient should improve immediately and respiratory distress and cyanosis should disappear. Epiglottitis resolved a few days after on antibiotics, and patient may be extubated after 2 to 3 days. So the intubation is mandatory in case of acute epiglottitis. We need to give oxygen supplementation, parenteral antibiotics, cefotaxime or ceftriaxone for 7 to 10 days, 100 mg per kg cefotaxime for 7 to 10 days. Neoplastic epinephrine and corticosteroid are ineffective, not like croup. So not need for those two cons. So in summary, epiglottitis is toxic emergency medical problems. Other cause of acute stridor, children, it's rare condition what's called bacterial tracheitis. It's a bacterial upper airway disease is mainly caused by Staph aureus, which include high-grade fever, virulent airway secretions, and absence of classical finding of epiglottitis. Most of patients if he's developed croup and he's not improved and his condition is worsening, he get more fever, more increasing respiratory secretion. This means he may develop bacterial tracheitis. So any patient with croup and deterioration, you suspect development of bacterial tracheitis. Treatment of bacterial tracheitis, antibiotic therapy usually includes antistaphylococcal agent. Artificial airway is indicated. Sometimes we can intubate the patient. Oxygen supplementation is necessary. Prognosis excellent for most patients. Patients usually become febrile within 2 to 3 days of antibiotic. So can give him anti-staph medication, nafcillin, cloxacillin, and other antibiotics. Other cause of acute stridor what's called diphtheria or laryngeal diphtheria. Diphtheria is an acute toxic infection caused by Corynebacterium species, typically Corynebacterium diphtheria. It's gram-positive bacilli, respiratory tract diphtheria, tonsil or pharynx. They are responsible for a site of infection for 94%. With the nose and larynx, the next site for infection. Incubation period of 2 to 4 days. In tonsillar and pharyngeal diphtheria, there are sore throat, mild fever, dysphagia, hoarseness, malaise, or even headache. Mild pharyngeal ingestion is followed by unilateral or bilateral tonsillar membrane formation, which can extend to involve the uvula, which may be cause toxic mediated paralysis. Soft palate, posterior oropharynx, hypopharynx, or glottic area. So this characteristic membrane, and it's look like a gray white membrane on tonsil, is characteristic for diphtheria during examination. Soft tissue edema and enlarged lymph node can cause what's called bull neck appearance in the neck. Fatality due to airway compromised or toxic mediated complications. Sometimes this microorganism secrete toxin that cause neuritis and other carditis, and this is responsible for the complication. This is by examination of tonsil, and we see a gray-white membrane. Sometimes dislodgement of membrane can cause suffocation. This was called a bull neck appearance of diphtheria. Cervical lymphadenopathy will appear by this picture. Diagnosis: specimen for culture should be obtained from the nose and throat and other mucocutaneous lesion. Evaluation of direct smear using a gram stain or specific fluorescent antibody is unreliable. Treatment: There are specific antitoxin neutralized only free toxin. So we give him specific antitoxin. The antitoxin is administered as a single empirical dose of 20 to 120,000 units based on the degree of the toxicity, site and size of the membrane, and duration of the illness. So the dose different according to the site of infection. Intravenous immunoglobulin preparation, their use is not proven or approved. Antimicrobial therapy. The benefit of antimicrobial therapy to halt toxin production, treat localized infection, prevent transmission of the organism to the contacts. So this is the role of antibiotics. You can use penicillin, erythromycin, clindamycin, or rifampicin. Erythromycin in dose of 40 to 50 mg per kg can be divided every 6 hours by mouth, and you can give a treatment for 2 weeks. Brochine penicillin 25 to 50,000 units per kg per day can be divided every 12 hours for 14 days. So this is the management of patients with acute diphtheria. Now we take another scenarios for another cause of acute stridor in children. A previously healthy 2-year-old child has developed a chronic cough over the previous 6 weeks. He had been seen in different emergency rooms on 2 occasions during this period and placed on antibiotics for pneumonia. Upon auscultation, you hear a normal breathing sound on the left side of the chest. On the right side, you hear decreased air movement during inspiration but not upon expiration. The routine chest X-ray shows no infiltration, but the heart is slightly shifted to the left. So, what are the most likely diagnoses? You can summarize the case. The baby is previously healthy. He had recurrent pneumonia, improving with antibiotics, and there are localization of the lesion on the right side, and there are shifting of the heart to the left side. So, what are the most likely diagnoses? There are no evidence of heart problem, no evidence of allergy. What could diagnoses? Choking or history of foreign body inhalation, and the baby had lost antibody and developed recurrent chest infection. So, what about choking in children? Choking or foreign body airway obstruction is most commonly in late infant and early childhood, from 6 months up to 4 years. When the baby starts to move and explore the around environment, he starts to swallow something and he can get choking. The most inhaled objects are food as bayonet, small objects, buttons, beads, coins, and safety pin. Clinical features. How the patient comes to you. Usually there are sudden onset of choking or coughing episodes. accompanied by wheeze are highly suggestive of an airway foreign body. And the mother come to you, my baby is well, he was playing with something, he was eating, he was have something small, something around the baby, and he suddenly start to cough, sinus, and become distressed. So you should suspect a foreign body inhalation. The most serious complication of the foreign body is aspiration. If of foreign body aspiration is complete obstruction of the air, and when there is complete obstruction of the airway, it may lead to death. There are 3 stages of symptom of foreign body inhalation or choking. Initial event is violent paroxysmal of coughing, choking, gagging, and possible airway obstruction. This occurs immediately when the foreign body is aspirated. Asymptomatic interval, second stage, the foreign body become loose. This is responsible for delayed diagnosis. The patient have foreign body and have coughing. Later on, the foreign body will stay in the gland and the baby is improving, and this is make missing of the diagnosis or delay the diagnosis. And we say many patients, they come with recurrent chest problem and later on they diagnose as foreign body. Complication, baby get with complication, obstruction, infection, pneumonia, hemoptysis, and atelectasis or lung collapse. So this is a 3 stage of foreign body inhalation. How can we diagnose foreign body inhalation? The most important is the history. A positive history must never be ignored. If the family say to you that my baby is choked, it's strongly suggested. A negative history may be misleading. If you suspect foreign body, you should check the baby properly. Examination depends on the site of the foreign body. He may get cyanosis, dyspnea, limited chest movement, tracheal deviation. So, all can be found in the patient's foreign body. Should check and examine. Hyperresonance percussion note due to air trapping. You may get hyperresonance. On chest auscultation, we may have decreased air entry, localized rhonchi, and crepitation. Usually in foreign body, the region is localized because on the site of affection of the foreign body. So when you collect all this sign and symptom, we may get a high suspicion of diagnosis. What investigation we need to do? Chest X-ray. Sometimes for radio or big foreign body, you can't get by chest X-ray, especially some metallic or others. Some vegetables or BNS can be not appear on X-ray, but their effect may be appear on X-ray. And what could a valve effect give us a valve effect? So on X-ray, we may find the radioic foreign body, we may find the pneumothorax, atelectasis, sign of hyperinflated chest, and emphysema. Bronchoscopy is diagnosed and therapeutic, using a flexible type for diagnosis and rigid type for diagnosis and treatment and expulsion of the foreign body. And most of the patients, when you remove the foreign body, the patient usually is improving. And this is an X-ray showing atelectasis of the right lobe, hyperinflation of upper and lower lobes. Example of foreign body inhalation. How can you consult the family with acute stridor? We keep the child calm. Acute stridor could be mild problem or life-threatening problem. Educate the family about the danger sign and home care of the baby. Ask them about possibility history of choking. Teaching about medication that could be given at home. This is important advice for the family. And thank you for your listening.